All right, thank you very much. Welcome once again, the Universal Healthcare Commission meeting, the June 11th meeting. This meeting is now being recorded. The recording will be posted on the commission's webpage. Usually takes a few days after the meeting. And I will ask Vicki Lowe, who is the chair of the Universal Healthcare Commission, to call the meeting to order.
Good afternoon. Thank you for being here. It is 2:02 and I call the June 11th meeting of the Universal Healthcare Commission to order. As per usual, we will read a land acknowledgement. I will provide the land acknowledgement again this time, but would like to encourage other commissioners to provide land acknowledgements in future meetings. I would like to begin by acknowledging that as we gather today, we are on the ancestral homes of Indigenous people. For me, that is the land of my ancestors in Jamestown, S'Klallam. We are here today in the lands of the Nisqually and the Squaxin Island people and other Coast Salish Indigenous people. Indigenous people, despite being removed from lands where they lived, hunted, gathered, practiced ceremonies, and cared for their community members, still care for these lands. Indigenous people and tribes, whether officially recognized by the United States government or not, continue to care for these lands and their community members. As health professionals, it is important that we also acknowledge the impacts of the removal from traditional lands, of children stolen to boarding schools, of the oppression of culture and traditional ways of life on the health of Indigenous people throughout the country and in Washington State. As we work to improve health in Washington State, it is imperative that we address the inequities of the past by understanding their impacts in the present. I invite each of you to learn about and understand the true history of the Indigenous lands where you reside. Thank you. I'd like to give a warm welcome to everyone for joining us today at the Universal Healthcare Commission. We have a full agenda as usual, so we're going to start off with roll call. Mary, do you want to do the roll call?
Sure, thank you. When I call, please unmute your microphone and let us know that you are here. Chair Vicki Lowe.
Present.
Vidisha.
Here.
Charles.
Present.
Dave.
Here.
Jane let us know that she is not able to attend today. Commissioner Cooter.
I am here. Sorry.
Okay.
Operator error.
Joan. Right. Okay. Representative Joe.
Here.
Okay. And I believe Mohammed is not here. He let us know he wasn't able to attend.
Oh, sorry. Actually, I thought I wasn't going to make it, but I was able. Thank you. Sorry about that.
Okay.
I'm here.
All right. Glad you made it. Nicole.
Here.
Okay. Omar.
Here.
And Stella. Yep. Is it Joan? Perhaps you've joined us?
Hi, I've arrived. Yes.
Hi.
Welcome. Getting my hard-earned panelist status.
All right, thank you, everyone. And before I turn it back over to you, Vicki, I just want to update folks. We're going to be talking later today about some staff changes and some budget changes, but I just want to pause to recognize that this is going to be Todd Bratton's last commission meeting. He joined this team last August. He has done a phenomenal job. He has worked with FTAC. He has worked with the commission. I'm pretty sure you can give Todd any topic and he can figure it out really quickly. But his position was funded through some proviso funding, and that proviso has not been renewed. So his position is sunsetting at the end of this month. So I wanted to pause and say thank you and great job. And we will miss your work. And Vicki, I'll turn it back over to you unless you want to say something, Todd.
Thank you. It's been a pleasure to work with y'all.
Thank you, Todd. I feel like I was just getting to know you. Thanks, Mary. And if everyone can turn to tab 2 in their materials. We have the meeting minutes from previous meeting. As a reminder, the recording of our last meeting is posted on the commission website. I'll entertain a motion for approval of the meeting minutes unless there's any discussion or proposed changes.
I move to approve.
Thank you, Nicole. There's a motion. Is there a second?
I second.
Thank you, Mohammed. All in favor, say aye. Aye.
Aye.
Aye. Aye.
Aye.
Any opposed, say nay. All right, motion approved. We can move to public comments. So if you turn to tab 3 in your materials, am I close enough? Am I close enough to the mic? Okay. Okay. Since our last meeting, we have received 4 written public comments. These comments include requests to address governance sooner in the work plan, suggestions for future cost modeling analyses, and general support for universal health care. Commission members received these public comments as part of the full meeting packet last Thursday for your review. Individuals may also provide public comment during this meeting. We will hear from them now. I think we didn't have anybody sign up ahead of time.
That's right.
Right. For those online, if you wish to give public comment, please use the Zoom feature to raise your hand. You'll be moved into the panel, as Mary mentioned earlier, when you are called upon, and this may take a few moments before we can hear you, so please be patient if you feel like there's a gap. When you are called upon, please state your name and any affiliation before speaking. We will be displaying a timer as a reminder for a 90-second limit. When the timer stops, please stop your public comment. Mary, would you please start with, I guess, anybody who has their hand up?
Sure, thank you. As Vicky said, we did not have anyone contact us ahead of the meeting to sign up to speak, so we will go right to the raised hands. And a moment ago, I thought I saw a whole Washington hand raised. Perhaps that person has been moved over to make a comment.
Hello, I believe that's me.
Great, thank you.
Hello, this is Andre Stackhouse. I'm the Executive Director of Whole Washington, and I'll be submitting this in writing and probably making this point a bit more articulately soon. But I just wanted to call in today to make sure that this commission was aware of the many resolutions for a state implementation of single-payer healthcare that are being passed across all sorts of unions and central labor councils, and we should be hearing more about that soon. And I think it's a great time to remind the commission that according to Senate Bill 5399, which created this commission, it is the law that this commission will recommend a state universal system with unified financing, including but not limited to single payer. So as we move forward across the rest of this year, it's not something that the commission is limited to. Of course, they may make other forms of recommendations, but ultimately we are expecting a clear recommendation for a way to proceed with a single payer solution for Washington. And so we remain available to discuss the details of that and presented legislation. And we're looking forward to the upcoming Advocates Roundtable where we can talk about that more. But with some of the things that have happened in the past couple of years, we think that there's a lot to move forward with state single payer. Thank you.
Thank you. And I think there was a hand up earlier. Was it Edouard? Is that how you say your name?
Yeah, that's perfect. Thanks very much.
Okay.
Hi, everyone. Thank you very much for listening. My name is Edward. I'm a resident of Kenmore, which is north of Seattle and Lake Washington. And I would like to speak today in favor of universal healthcare in our wonderful state. In my opinion, healthcare should be a right and not a privilege, but also healthcare makes economic sense for our residents and for our state. The 3 elements I'd like to share with you are that there's a recent study that's really interesting, strongly recommended, shows that people who gained Medicaid coverage via the ACA were 21% less likely to die in the year of their enrollment than those who did not get health coverage. Surprisingly, health insurance plays a role in improving the health of our fellow humans. Incredible. One of the data points that I also like to share is that for every $100 spent on healthcare, $20 go to administrative costs if they go through private insurance, but only up to as low as $2 go to administrative health costs if administered through Medicaid. Universal healthcare means more dollars spent on healthcare itself and not on shareholder benefits or administrative overhead. And the final element I want to share is also supporting universal healthcare is the sound rationale and it. The only way to minimize health insurance related risks is by maximizing the risk pool. We could deny every claim, but I don't think we want to go there as well. The best way to maximize the pool is to have everyone, healthy or sick, be under the same umbrella. Healthcare is not a moral issue, it's also a practical economics one. Thank you very much.
Thank you. I am not seeing any other hands raised. We'll give it just, oh, there is someone. My apologies for that. And you know what? I missed whose hand it was. Can someone let us? Oh, Catherine Lewandowski. Thank you.
Thanks. Apologies for that. I think it went down when I renamed myself. Thank you, Chair Lowe and members of the commission. For the record, my name is Catherine Lewandowski. I'm a retired registered nurse from Arlington, Washington, and volunteer board vice chair of Whole Washington. Thank you for all the work that you do. I am so excited to see in your meeting materials that there's some money from the OIC for some potential studies, and I wanted to let the commission know that we've received recommendations from some of our volunteers who have been extremely impressed with the work that's come out of Western Washington University's Center for Economic and Business Research. I'd be happy to send you their contact information. We had a very good exploratory meeting with them last winter to discuss a potential funding analysis for the Washington Health Trust. If there's money for another analysis, I think using their service would be very informative. I wanted to thank you for scheduling the upcoming advocacy meeting on July 14th. We appreciate being included in this very much and are excited to participate. I also wanted to mention that I also appreciate the information provided by Dave Chase, both at your last meeting and also in his written comments regarding the possibilities of designing a universal healthcare system around a public benefit corporation governance model. I personally really like the public benefit model, and I hope that the members of the committee are evaluating that also. Although I do believe that the Washington Health Trust is most affordable and most comprehensive, it is designed to be transitioned into place over time. We are possibly moving into a healthcare crisis situation, especially for our local communities where there just is no time to spare. Assessing Mr. Chase's social cooperative plan could be a faster way to rescue our rural hospitals, especially from almost certain demise. And to be clear, the majority of people in Washington and in America are hungry to be released from the predatory practices of our for-profit middlemen. Thank you for your time.
Thank you. Okay, now again, I am not seeing hands. Did I miss anyone? All right, I think that's the end. Thank you all for your comments. And Vicki, I'll turn it back to you.
Yeah. Thank you, everyone, for your comments. As a reminder, the commission welcomes and encourages public comment and appreciates all feedback received. Public comments is an essential part of this process as it provides an opportunity for the public to have their voice heard at regular meetings. Public comments can be provided orally during the meeting or in written form at any time to the commission's inbox, which is HCA Universal HCC at hca.wa.gov. And I believe someone will drop that in the chat box. Oral public comments are not accepted outside of the public comment period. Commission members review and consider all public comments received. Hopefully, it is evident that public comments are heard, as evidenced by the ongoing discussion regarding potentially accelerating the timing on governance. Commission members generally will not respond to public comments during the meeting. If the commission deems it appropriate, a response will be provided in writing or at the next public meeting. So thank you, everyone. And now we are going to hear about interstate healthcare compacts from Insurance Commissioner Patty Kuderer. Commissioner Kuderer?
Yes, can you hear me?
Yes, we can.
All right, good, good. Thank you so much. Very much appreciate the time that I have to talk to you a few minutes about what I have actually talked about before, an interstate healthcare compact. So I want to just start by saying that our neighbor Oregon it has already been working in this area for several years. They have a healthcare reform modeling that they've been looking at, and their legislature established their own universal healthcare plan governance board in 2023. And they are working to deliver a final report to the legislature in mid-2026. And as I'm sure this doesn't come as any surprise to you, in a number of respects, Oregon and Washington are engaging in parallel research with similar goals to design a universal healthcare system. And similar to the comments that we heard during the open comment period, I'm also a big believer in universal healthcare, and it is really one of it was the main driving reason that I sought the position of insurance commissioner in the first place. And because of the work that's going on in Oregon and the work that's happening here in Washington, I think our states not only share that same desire for universal healthcare system, but we also share some of the same insurers and health systems. So that makes us perfect partners, I think. And the ACA included Section 1333, which was initially designed to allow states to work across state lines to allow out-of-state sale of health insurance. And while this option has not been taken up, the new Consumer Information and Insurance Oversight Director, the CIO, Peter Nelson, has published an issue paper noting flexibilities offered to states under a Section 1333 compact. Section 1333 contains what we call guardrails. For example, it prevents healthcare choice compacts from offering coverage that is less comprehensive or affordable than under the ACA exchanges. And of course, here in Washington, we codified most of the ACA already into Washington state law. And I was proud to support that work when I was in the legislature. And so to this end, I would like to propose that at the September 2025 UHCC meeting, that we invite Oregon to learn more with us about 1333 compacts. And we could work to find speakers who could speak on the provisions of Section 1333 and open a discussion with Oregon as to whether there might be opportunities to work together on pursuing a universal healthcare system that benefits both states. So again, thank you for your time today, and I appreciate you considering that.
Thank you, Commissioner Cooter. Are there any questions or comments from the commissioners? I think then it's okay to work with staff on scheduling that, Mary?
Yes.
Okay. Thank you. We'll be working on that.
All right. Thanks, everyone. Have a good day.
All right. And now's the time to hear from the rest of the commissioners on state agency updates. I think we're considering that our OIC update, right? Or is Nico?
Yeah,
Okay.
unless there's more to add, but yes.
Okay. So going in alphabetical order according to first name again. Starting at Charles is not here, right? Is he here? Okay. Charles, you're first. Sorry, maybe I should go backwards next time.
No, it's fine. Yeah, I guess, the major update for us, obviously, is the announcement by the governor's office this week of the new Secretary of Health. Really excited. The decision of Dennis Washam, who currently leads Snohomish County Health, to be the next Secretary of Health. We can't think of anyone more qualified and suitable for the role at this moment. So really excited and looking forward to welcoming him as a secretary beginning next month. I think, that's really the major updates that we have right now. Obviously, beginning to get ready for the next biennium, the next not biennium, the next budget session, and aligning our priorities and working through the process. That's my update.
All right, thank you. Dave, you're next.
All right. So for the Healthcare Authority, a couple of different things. We don't have a announcement of a permanent director at this point, but we're hopeful that we'll hear something this month. So congratulations, DOH, us and DSHS, and I think it's ESD are still with our interim and acting directors. For federal activity, just a couple of things. A couple. HCA and DOH posted updates related to the federal government's administration's notices related to EMTALA changes and gender affirming care. And just want to confirm that Washington residents still have access to care, and hospitals in the state still have obligations to continue providing such care. So there's been some activity in that area. Our agency, like many others, is closely monitoring and assessing the federal budget that's working its way through Congress. There are a lot of significant impacts that could be felt on residents and disruptions in programs like Medicaid and our marketplace in particular. I'll let Joan talk a little bit about the marketplace things. I'll do a quick overview of some of the bigger components for Medicaid. And so we've been interacting with the congressional office on various challenges that would be inherent to implementing the bill in its current form. So just at a really high level, the federal reconciliation bill would have new limits on Medicaid coverage, especially for expansion adults. That includes more work requirements and more frequent eligibility redeterminations. It broadens prohibitions on reproductive and gender affirming care for all ages, not just those under the age of 19. It discourages Medicaid program coverage for non-citizens by reducing the federal match that would come for expansion adults in states where there are certain non-citizens in Medicaid. And then there's impacts in the marketplace, enrollment and affordability area, changing the window, constricting eligibility, reducing the premium assistance, things that I'm sure Joan might touch on as well when we get to the J part of the alphabet. Let's see. Moving from federal government. Federal government, I would just highlight, if people aren't tracking that well, the federal fiscal year ends September 30th. So that's often thought of as when Congress has to act on the federal budget. But there's also the debt ceiling limit, which is really the de facto deadline of all of this. And that's projected to be hit in August. So that's the timing I think we're all watching, a little bit closer than the September timeline. When it comes to the state budget, you are probably well aware that there are reductions that are being worked on across state government, including in HCA programs. I think Mary's going to talk a little later about the impacts for the Universal Healthcare Commission, although we had a preview at the opening. And we are still working as an agency on a lot of our internal reductions and haven't made any specific announcements on implementation of things as an agency. We're also very aware that the governor's office has previewed, there's a budget revenue forecast coming in about 2 weeks, and that we're all expecting the next year to continue to be challenging. So our agency has been very proactive in really cranking hard on things like travel freezes, hiring freezes, contract, the way that we review contracts up for exemption from the freeze process. We've been very diligent from the beginning, and we're going to continue to be a very diligent agency when it comes to that to promote as much efficiency as possible and manage any reductions that have to be taken in government. I'll highlight from the PEB and SEB perspective, we are off to the races on implementation of what is Senate Bill 5083, which is the reference-based pricing bill, or the Public Employee Affordability Bill. Choose your own name, so to speak. It's all the same thing, but we are officially kicking off the rulemaking process. Our hope is to complete rulemaking so that the rules of the road are really clear to the provider community and the carriers that are in the PEB program by the end of the year, because they will have a lot of contracting efforts to go during 2026, because that bill actually goes into effect in 2027. I think that's a really important reminder that I like to highlight for people, is because there's a lot of talk about the impacts of that bill and how they're impacting decisions today, but the bill and the rates and the rate caps that are part of that bill don't exist until 2027. So there's work towards implementing them, but those reductions, if there are individual providers or facilities that are over those caps aren't law until January 27. So we can all begin working towards those, but they don't actually impact today's budget, so to speak. And then last but not least, on the PEB sub front, we have our commercial plan rate activity process. This is the time of year for that. We should be announcing our PEB and SEB rates here at the end of June publicly. Just a reminder, because a lot of people look at different parts of the market and try to compare them. Don't forget that we publish the premiums that the employee owes, and that is definitely heavily impacted by the collective bargaining agreements and the contribution from the employer. So when you look at, say, a % increase in PEB or SEB, we're just doing the cost share, the premium contribution from the member. We're not really showing the whole bid rate and the underlying growth increase. So it's really hard to sometimes do an apples to apples comparison. But if anybody has any questions once we publish them, happy to talk about it some more. But just don't take them, put them side by side from other parts of the market and think it's an apples to apples comparison. There's a little bit of a extra math conversion you got to think about whenever you're looking at PEB SEB rates. And I think those are some of the bigger things that I have.
Thank you, Dave. Any questions? All right. And did Nico, I'm going to go out of alphabetical order and have Nico, if you're subbing for Jane, to have a report out for us.
Thank you so much, everybody. For those I don't know, my name is Nico Jansen, and I'm a policy analyst for the OIC, stepping in to cover for Jane, who is at a family wedding and can't join us today. I wanted to add that the OIC released, excuse me, the proposed individual insurance market rates for plan year 2026 at the end of May. The carriers are proposing a weighted average rate of about 21%. We put out a release in our rate review process. We'll be going from now until the fall. So those aren't the final rates, those are the proposed rates. But I would add, and this is something we emphasized in our release, that a significant factor in those proposed rates is the expected expiration of the enhanced premium tax credits. Our actuaries are digging through the rates to understand them. So, you know, our work is ongoing, and then the federal uncertainty. So that's something that we put out there and we'll continue to work on as we anticipate these myriad uncertainties from the federal government. We're also starting our rulemaking processes for all the bills that were passed. So that includes a lot of bills that we're beginning rulemaking on. So those are just some updates from the OIC. Thanks.
Thank you, Nico. Mohammed, I saw your hand go up kind of in between there. Did you have a comment or question?
Just a quick question, and anybody who has the information can, and I might have missed it when it was presented, but a lot of the community members and what we're seeing here on the ground is people worry about the new bills, the proposed bills' impact on Medicaid and Medicare. A lot of people are afraid they're going to lose coverage, or I just wanted to get maybe we have the best experts here. So if that would impact our state, or that we can some way shield that from Washingtonians from what's going on in DC.
This is Joan. I can take a stab at a general number. I know there are a lot of national analyses. A lot of consultants are getting paid a lot to try to estimate the impact of the myriad of federal activity on state coverage. And I'll just note that an analysis I saw recently from the Kaiser Family Foundation that was updated on June 6th, looking at the information available from CBO and making some Medicaid estimates, did say that they expected that the uninsured rate in Washington would increase by 5%, which would essentially double our uninsurance rate in Washington. And it was one of the highest jumps in projected uninsured rates in the country. And also noted that the number of people expected to become uninsured was just under 500,000. So that was just one organization's take on what the potential impact could be when you look in aggregate at the proposed marketplace change and what's currently in the House passed version of the reconciliation bill. And all of the estimates sort of vary based on the method being used and the time frame being projected. So it's hard to sort of compare apples to apples across all these different analyses that are being done. But it does try to roll it all up and take a state-specific look at what could happen here. I know Healthcare Authority has also done some estimates of the specific kind of Medicaid-based impacts, and I know we're in the process of working on the individual market-based impacts as well, but they're significant. And, to the extent that we're relying on federal funding, and to which we have to follow federal law as it relates to eligibility, we are looking at mitigation strategies. I would say, and invite other state agency reps to speak on this. They're in some of the ways that the bill and the changes have been framed. They're sort of framed in a way where you either comply or lose all your federal funding, which would be a very hard amount to try to backfill at the state level.
Thanks, Joan.
So-
I'll add on. First, I was looking to get the report that is now in chat as a response to Representative Schmick's question while the question was being asked. So thank you for doing a really good job on setting the table, Joan. I just wanted to add, there are a variety of estimates that are out there. None of them are small numbers. When we talk about the dollars, we're usually talking somewhere north of 2, 3, somewhere in the $4 billion range per year. And we're talking about the number of covered lives that could have disruption in Medicaid. Joan highlighted a number as high as 500,000. I'll tell you that I've seen no numbers that are below 100,000. So we are talking very significant numbers. So lots of different models, lots of different reports, but they're all pointing in the same general direction of very large numbers, multiple billions of dollars, multiple hundreds of thousands of individuals potentially losing coverage just within our state. And then at a national level, we're talking the numbers that are often reported are in the 15 to 17 million individuals across all the states that could be losing Medicaid as a result of the reconciliation bill if it passed in its current form.
Thank you, Dave. And Mohammed, did you see the document that Ali put in the chat? I think it.
I did. Thank you both. Thank you, Chair.
Thank you. And so, Joan, I think if you had more to add to your comments.
I wish there were a more uplifting update, but again, Joan Altman, I direct coverage strategies and expansion at the exchange. I would say at the federal level, watching in great interest what happens with 2 vehicles, well, really 3, but there was a series of executive orders that was issued that were sort of directed various federal agencies to identify ways in which access and costs could be further addressed. And so waiting to see sort of what recommendations may fall from the executive orders that were issued in the last 30, 60 days. 2, there's a proposed marketplace final rule that we're expecting any day now that would make a number of proposed changes for the upcoming plan year that would restrict access and sort of further erode affordability. Things like kind of narrowing the open enrollment period, narrowing who could enroll mid-year, looking at verifications, limiting auto enrollment. Things that we think will create barriers to access for customers, and then closely watching the reconciliation bill, which in addition to the pieces Dave mentioned, I would say pose a threat to our waiver as proposed. You couldn't continue offering services to people who are not citizens and don't meet the new definition of lawfully present that's being proposed beyond, sort of starting at the end of 2027 and onward. So that would really roll back the sort of iterative gains that we've made. It also restricts the people who are currently considered lawfully present. It further reduces the scope of that population pretty significantly. So sort of newly categorizing some people as undocumented, and then also challenging state level programs, even if they're not funded at all at the federal level, which ours is not. Sort of making continued receipt of Medicaid funding contingent on sort of ending those programs writ large. So watching that with some interest, in addition to the Medicaid pieces and the further pieces that would sort of, of interest to this committee was the exchange looking at auto enrollment and facilitated enrollment for people coming off of Medicaid. We got some legislative support this session to look at putting in a way to sort of further facilitate enrollment into the exchange. These bills contemplate kind of restricting the ability of exchanges to automatically enroll people, which would again sort of hinder those efforts. So looking to see ways that we can continue to move forward, continuing to move forward in planning for the 2026 plan year, taking a look at the rates and how they might impact exchange customers and how they may change moving forward.
Thank you, Joan. Any questions? All right, and last but not least, Omar, do you have anything to share?
No updates, but I think along with everybody else, just tracking what's going on at the federal level.
Yes, thank you. I think we're all doing that. All right, thank you all for those updates. I know it's not always good news, but at least, to help be in the know and know what to support is really important. So now if you can turn to tab 5 in your commission materials, Mary and Todd will update us on our work plan.
All right, thanks, Vicki. I'll get us started off. The next slide, please. A few announcements about some upcoming meetings. We've changed up the schedule a bit this year. A few people have already mentioned that we have an advocates roundtable coming up on July 14th. I'm very happy to hear interest in folks participating. We're looking forward to it. We're still pulling together all the details on that one. It will be, in terms of running the meeting and attending the meeting, it'll be just like the meeting we're sitting in right now. The folks will be in person here in Olympia, in fact, in this same room. Also, people will be able to attend via Zoom, and it is a meeting that is open to the public, and we have extended the invitation to commission members and to FTAC members, as well as, any folks from the public are welcome to show up. So more details will be coming out about that. We also have changed the date of an upcoming commission meeting. We had one on August 14th. We've decided to move that to September. So the August meeting is now a September meeting. Again, same structure, same room, same everything, just happening on a different date. And we'll continue to send out reminders so folks know about that change. The next slide. We are working on the annual report. It's in the work plan. I think it's feels like it's always orange or always yellow because we're always working on at least one annual report. We're working on the 2025 one. We're going to follow a process pretty similar to what we did last year. An initial draft will be circulated to commission members sometime in the month of August. At the September 11th meeting, we will ask for your feedback, any suggestions. You can give it to us in writing. We can talk about it at the meeting, whatever works for you. But September is when we are hoping to hear some feedback and some comments. Staff will then make further revisions, further additions. And at the October 9th meeting of the commission, that's when we will ask for commission approval of the final draft. And then it's due to the legislature on November 1st. And now the next slide. Our budget update. Yes, we did allude to this earlier today. Our last meeting, the state had not passed its budget. The governor has not signed it. It's now signed. We are looking at a staff reduction. Right now, there are 3 of us devoted full-time to the commission. That number will be going down to 2 of us. And we will not have outside consultant support after June 30th. If you are interested in the details of the budget, the baseline funding is the same as what was in the 2023-2025 budget. The reductions and the changes we're seeing are due to changes in proviso funding. The additional staff person and the consultants were funded by a proviso that was in the previous budget. That proviso has ended and it was not renewed. What we do have going forward is different proviso funding that comes from the Office of the Insurance Commissioner. That will be in the next biennium. And the next slide gives us the text of that. So there we go, our upcoming proviso, $250,000. The Office of the Insurance Commissioner working with the Healthcare Authority to support economic, actuarial, or other modeling related to the design of a universal healthcare system. So the commission staff and OIC are working together to identify possible analyses to be carried out with this funding. So there will be more information on that as we go along. And our next slide. All right, I'm hitting many topics very quickly in this deck. Here we are with our milestone tracker. Just a reminder of where we are, where we sit in the work that we are doing. To the far right, you see the legislative report. This should look pretty familiar by now. And our next slide. Today's meeting, we will be hearing feedback from FTAC and the commission and decisions about these next steps. So all of phase one, the topics we're hitting upon today will be hitting the green and then the other orange ones as well. And the next slide. Looking at our work plan, just to remind us of where we are. Here we are in June. You're hearing about cost containment and some preliminary recommendations about benefits and services. And then if we go to the next slide is the second half of the year. Feedback about benefits and services will go to FTAC for their July meeting. And then the final recommendation for benefits and services, that's now a September meeting. So that's not a typo. It should say September. And again, we have noted the legislative report and the other topics where there will be some preliminary recommendations. And our next slide. Again, okay, another topic in this deck. We are proposing that we update the charter for FTAC. We are considering updating an attendance policy. And the whole charter is within your deck. This is the part that we are considering a change, talking about regular attendance at FTAC members. If a member misses 3 meetings in a calendar year or 3 consecutive meetings in a 12-month period, FTAC member will be notified by HCA staff supporting the work of the commission that they may be removed due to attendance. So the proposed rewrite and what is on this slide is that they may be removed. There was some internal discussion because we looked to the charter of the Healthcare Cost Transparency Board, and I believe theirs says will be removed. So the healthcare, the cost board says will removed. This one right now says may be removed. So we are looking for commission feedback, possibly approval of a charter change, but I wanted to pause to see if there was opinions or feedback about whether it should be may be or will.
Mary, would it be okay if I gave my 2 cents on the meeting? Ross Valori, Director, Board and Commissions here at HCA. We had this discussion also with the Healthcare Cost Transparency Board about the may or shall language regarding removal, and the situation that I'm just thinking of in favor of the may language is a scenario where there is an otherwise excusable absence or some other series of unfortunate events that prevent a member from attending for 3 meetings. And I'm sure we could all envision different scenarios where that would happen, and wanting to provide the commission members with the flexibility to be able to determine if that's appropriate or not. That would be the argument for including the may language. Of course, if you have the will, it makes it much simpler to make a decision if that series of events occurs. So just wanted to add that additional context. Thank you, Mary.
Thanks, Ross. Oh, Representative Schmeck.
Thank you. Has attendance been an issue in past FTAC meetings?
Okay. Yes, it has. Badisha.
So if attendance has been an issue in the past meetings, has it caused problems or delayed the analysis, or that has just gone on even if attendance was not an issue?
Yeah, sure. Thank you for that question, Badisha. This is David DiGiuseppe, the FTAC liaison to this commission. The attendance issue has not slowed us down at all in terms of our analysis. I would just say that there is one less seat, one less perspective potentially represented.
I don't see any other hands. Vicky, do you want to?
Yeah, I think, do we want to take a vote then and see if we want to change the language from may to shall?
And also,
Right.
well, there's actually two questions, I suppose.
Okay.
One is to update the charter to include this an attendance policy.
Mhm.
And then the second question is maybe versus will.
Okay, so in two parts then.
Yeah.
Is there any discussion on updating the attendance policy? Representative Schmick.
Thank you. So currently, there is no attendance policy for FTech. So this would be installing it. That's one question. And then I'm just clarifying. And the second one, that it leaves it up to the rest of the commission to remove someone, or we're going to make it permissive, or we're going to make it must. And is that the gist of the of everything here? Just want to be clear.
Thank you, Commissioner Schmick. Yes, I think as long as the commission members are okay, I think it could be a two-part motion where, as you noted, the first question is whether commission members are comfortable updating FTAC's charter to reflect an attendance policy. And yes, you're correct. There's not a currently existing attendance policy. And then the second part is whether the commission supports modifying from will to may to provide the commission with authority to make the determination based upon facts and circumstances of each scenario, whether an FTAC member should be removed. And if you have any other questions, please let us know. Thank you.
Omar?
Thank you. And so I think we're open for discussion right now too. As far as like different groups too, I think one important piece that I've had history with is being able to have active communication with staff. And so I get that things come up and emergencies happen, but I think an important piece is to potentially include that there is consistent communication with staff to let folks know, if they are going to be missing a meeting or something like that. And I would lean on the may language just to give flexibility to staff, and I think folks on being able to make I guess case by case, being able to have the flexibility in case folks are missing because of emergencies or things like that.
Thank you, Omar. Any other discussion?
Chair Lowe. I'm happy to also say that I'm supportive of having an attendance policy. I think that it's an important thing to lay out expectations like that. And I'm perfectly comfortable with the discretionary instead of the mandatory removal process. So I'm willing.
Is that a motion?
I'm willing to make a motion to update the FTAC charter essentially as described on what slide number is that? Sorry.
31.
On slide 31 in our books today, so that we incorporate an attendance policy that includes the permissive ability for the commission to ultimately have the discretion to remove an FTAC member for attendance challenges.
Mohammed? did you have a comment or a
Oh,
second?
just a comment. We because of the timeline that we're running, how tight it is. This, I mean, I'm for the charter, but maybe if it would open us to, if we lost like one or two or even an important leadership position in the FTAC, that might impact our timeline. So I mean, just cautioning that, but we might just leave it the way it is. But I also see my colleagues' points as well. So I'm on the fence on that.
And if I may comment, I get what you're saying. I think that's how the word may rather than will can help us out. But if there's someone, and I believe this is the situation, who just hasn't attended, and it would be helpful to fill that position with somebody who can make the meetings and give their input so we can get their perspective. Having a policy would actually help the FTAC make that happen. Nicole.
Okay, I was just gonna second, I think that was Dave's.
All right, so we have a motion and a second. Is there any other discussion? All right. All those in favor of accepting the attendance policy as written on slide 31 here in our deck, please say aye. Aye.
Aye.
Aye.
Aye.
Any opposed, say nay. Motion carries. Oh, wow. We are a little bit ahead.
Actually, I think there's a little bit more. I
Is
think
there
you
more?
have, the
Okay.
very end of this tab belongs to you, Todd. Jen, if you can scroll through this, now this is the whole charter. We can keep going. The new section is in red type at the end. Oh, and there we go. The next slide. All right, Todd, I think this one's yours.
Hello, Commission members. I have a quick update on cost containment as it relates to the work plan. And first, I want to start by emphasizing this is a staff update, and the Commission may direct HCA staff to revise this approach as necessary now or in future planning sessions. And so looking at the image on the right, we see cost containment listed in the key design elements for a unified system. And these came from the legislature and ended up in your work plan. So HCA staff anticipate that the status for this cost containment bubble will remain in progress as the Commission's work continues. And this is because of the two specific ways the Commission addresses cost containment. The first is by identifying transitional solutions. For example, the Commission's review and support for reference-based pricing in the public and school employee benefit programs. That was a cost containment effort. The 2025 work plan returns to transitional solutions going forward from here, and there may be new ways to address costs depending on current proposals and the priorities of the Commission. The second way the Commission addresses cost containment is by working on the key design elements. For example, in the benefits and services bubble, the Commission has been addressing costs and cost-sharing alternatives, establishing cost-sharing principles, and conducting a cost analysis study, and making recommendations based on this work. Over the next few meetings, the Commission will be discussing the key design element, provider reimbursement. Likely, there are opportunities to discuss and address cost containment within that discussion and develop options for cost containment around provider reimbursement. Further into the future, the Commission is likely to address cost containment in the infrastructure or governance and administrative design work. Healthcare Authority staff are documenting the Commission's approach along these lines and in more detail in the annual report to the legislature. The Commission members will have a couple of chances to review, revise, or adjust that report before its submission in November. And to summarize this, the cost containment work is ongoing and directly connected to either transitional solutions or the specific work on the key design elements. And for this reason, HCA staff will continue to consider cost containment in progress unless directed otherwise. Are there any questions about that or anything we can help clarify? Thanks so much.
Okay. So thank you for the discussion. It's time for a short break. We okay to go to break or you want to? Yeah,
that work?
everybody wants a break? All right.
Built in 2 shorter breaks
Yes.
this time around.
Okay, so a 5-minute break. And then we'll come back and David will give the update from the FTAC and we'll make some decisions about the next steps for FTAC. So it is 2:56, so that has us coming back at 3:04. See you then. All right, I want to apologize for my math skills. That was actually a little longer break than 5 minutes, but I think we all needed it. And, you know, for being ahead for once in like forever, I think we deserved it. So welcome back, everybody. If you turn to tab 6 in your commission meeting materials, we will be ready to hear our update from David Giuseppe, the FTech liaison. David?
Well, thank you for having me back. I'm going to go over initially what we talked about at the May 15th FTAC meeting, and then I'll be blending in this idea we've come up with about a work group, the last bullet item here. I'm going to start by reflecting on the public commentary that we received. When I presented to you on April 17th, you asked me a question about governance and how that affects how a decision or no decision affects FTAC, and I wanted to take that question back to FTAC, and so I have a report out for you on that. Similarly, when I presented to you the work on the benefit cost analysis, you asked me some questions that I felt it appropriate to take back to FTAC to get some thoughts about that to bring back here. At the same time, when I brought those thoughts back to FTAC at the May meeting, my fellow FTAC members were asking questions about, you know, does the commission understand the nuance of a decision that you made at the April 17th meeting? So I want to share with you those questions that we were addressing at FTAC at our May meeting. And that ties into this work group idea where we came up with the idea that given how short the time available to have these discussions on some pretty comprehensive and meaty issues are, we came up with this concept of a blended commission FTAC work group that I'll tell you about. Finally, we'll talk about the role of what FTAC can do with cost containment versus what the Transparency Board is addressing with cost containment. So Jen, if you could go to the next slide, please. So we got relatively minimal comments at our May meeting, and the primary theme was advocacy for a universal system, which is what you'd expect to hear, and we have heard consistently. Next slide, please. As you all discussed governance and this question of accelerating governance, one of you asked me if we do or don't accelerate the governance question, does that impact our work at FTAC? So we talked about that last month, and the general consensus was no, our work would not be accelerated by accelerating the governance conversation. And you know, I want to be clear and say that generally speaking, FTAC members appreciate the reasons why the advocates have come with public comments, expressing a desire to accelerate the question of governance. Some of you at the April meeting talked about the reasons for doing so, but in general, we felt similar to, I think, what you, Vicki, mentioned at the April meeting around a bottom-up approach where we start with the total cost of care, the medical services, and you saw in my report out the scenario 2 that you all landed on, the PEB-SEB design being applied there, has an additional cost estimate ranging from $1 billion to $4 billion. And because of that, it generally makes sense to FTAC members to deal with the design of the system, the feasibility of achieving that unification, and then layering on the question of the infrastructure and the administrative design, and does that save money and work against that increased cost on the total cost of care side. And I think you heard Todd describe that some of the later phases teed up for FTAC right now after provider reimbursement is that infrastructure question. Does anybody have any questions on that? Okay, Jen, can we go to the next slide, please? Okay, so I'm going to go through a few slides that are similar to what I showed last month in terms of the staging. the various components of the cost analysis. And you'll see in that a purple section where we have highlighted questions for this work group that we're proposing. So the intent of the work group is to see if we can get 3 of you as commission members to join roughly 3 FTAC members to have some conversations on the side to get into some of those nuances that you'll see in the slide today. So as we're going through these slides today, if the purple questions pique your interest, you might be a great candidate to join us in this conversation. And the purpose of doing this is so that when I come back to these meetings and have these relatively brief report outs, if any of your fellow commissioners have questions about the nuances or you feel like there's an important point that the whole group needs to understand, you could be a spokesperson in that capacity. Next slide, please. Okay, so we touched on benefits and services. The blue section here are the decisions that you all made last month in response to my FTAC report out. And I have to say, we all at FTAC were impressed with the decisions that you made. There were a fair number of important decisions that we got through. So on the benefits and services, you all decided that we at FTAC didn't need to worry about modeling additional benefit designs beyond the 3 scenarios that we showed you. You decided that aiming for scenario 2, a PEB-SEB design, is appropriate when you saw the costs of the 3 different systems, the cost estimates, I should say, of the 3 different scenarios, yet wanting to aspire to scenario 1, and that was no cost sharing Medicaid benefit design, essentially. On the other end of the spectrum, scenario 3, which was the Cascade Select Silver, Cascade Care Silver design, keeping that on the table as a point of reference. There was one question about vision benefits. Can that be included in the design? And one question about, is it appropriate to assess higher cost sharing for more expensive services? When I took this back to FTAC, this is an example of the nuances that my fellow FTAC members want to make sure you all understand in making these decisions. So in the modeling that we did to create these scenarios, we assumed that folks who are eligible for Medicaid benefits today under current criteria would continue to receive Medicaid covered services even as other folks would be experiencing the PEB-SEB benefit design, and that they experienced $0 cost sharing even while non-Medicaid eligible folks would be experiencing PEB-SEB levels of cost sharing. So then we discussed those questions to try and give you something to react to. So the consensus, you'll see in these bottom sections of my report out that in some cases FTAC came to consensus and in some cases we did not. So on these issues, we felt that no, everyone who is covered under the new system should have the same covered services. So if you are on Medicaid today and you have Medicaid benefits and those Medicaid services being covered, and those are slightly richer than what PEB-SEB covers, that under this new system, those extra benefits you get in Medicaid would be reduced so that you would experience the same benefits as folks who are on the PEB-SEB coverage. We also felt that, yes, individuals who meet the criteria for Medicaid coverage, and this 138% of the federal poverty level is a current threshold, and that could be modified by you or the legislature. But yes, they should continue to experience $0 cost sharing. So we went 2 different directions you're seeing there. No on the benefits, yes on the cost sharing. We did clarify that vision is covered under PEB-SEB. So I think when one of you asked about vision being covered, I think, yes, it is. So that shouldn't be an issue. And then we had a fair amount of debate on this issue of, or the question of, should higher cost sharing be applied to higher cost services? And you can see here that, on the one hand, if there is a coinsurance design, that automatically happens because a coinsurance says member or health plan or covered person's cost sharing is 20% of the allowed cost. And so as that allowed cost goes up, your 20% fraction of that goes up. At the same time, what that does is it concentrates the cost sharing burden on a smaller number of people who need that service as opposed to spreading it out. And early on, I think it was last fall, FTAC drafted some cost sharing principles that you all adopted. And there was some concern at FTAC that if that model was approached, it might go against the cost sharing principles that we all came up with. Okay, next slide, please, Jen. So what we're proposing from the work group standpoint is that this question of services should be well understood by the commission before developing a recommendation. So spending some time articulating and defining what are the exact differences between Medicaid covered services, PEB/CEB covered services, and Cascade Care Silver covered services. Likewise, the question of cost sharing is important. So confirming that you all want, in adopting scenario 2 in the PEB/CEB design, are you saying that you want that to be both the covered services and the existing cost sharing structure? Or do you want it to be the actuarial equivalence of that cost sharing structure, but potentially a different detailed cost sharing design? And what I mean by that is when you price out the total cost of services, you might say, okay, well, members are going to bear 20% of that cost in the form of cost sharing in aggregate. The next layer of detail is, well, which of those services would have a copayment? So maybe outpatient surgery has a $500 copayment, primary care has a $0 copayment, but radiology services has a $20 coinsurance. So all of that's already specified under the PEB/CEB design. And so the question for you all is, are you proposing to follow that exactly or in principle, but differences in detail? Okay, any questions there? I feel like I need to come up with some jokes or something because it's super dry. Okay, next slide, please. Yes. Okay, on the question of eligibility. Yes, Joan.
Hi, David. I don't know if this is for you or Dave, but I just had a quick question about offhand, if we know what percentage of the benefit design under PEB/CEB are copayments versus coinsurance.
Co-insurance tends to predominate in non-pharmacy parts of the medical plan, and co-payments tend to persist in the pharmacy part of the design. There are some co-payments on the medical side, but the vast majority is a co-insurance model except for pharmacy, which is co-payment. Does that help, Joan?
Yeah, it does. Thanks. I was just thinking about the shift in access we've seen in designing the standard plans that are designed to be co-payments, not co-insurance. And thinking about your question, David, about PEB/CEB.
Actually, I should get a bit more nuanced. And now that I'm thinking about it, I was like, so in PEB and CEB, we have self-insured plans, a uniform medical plan, and fully insured commercial plans. On the self-insured side, it's co-insurance, except for pharmacies co-payments. On the fully insured side, it tends to be more co-payments, even outside of pharmacy. But the vast majority of enrollment in PEB and CEB is in the self-insured plan. So the most consumer experience is generally a co-insurance model. But those who are in fully insured commercial plans tend to have co-payments. On PEB, the enrollment between self-insured and fully insured is roughly 80% of the enrollment is almost in UMP at this point. On CEB, it's about 43% is UMP and 57% is fully insured. So that just gives a little bit. So I usually frame my answers from a UMP standpoint, but I figured I should be more nuanced here. It's a little bit of everything.
That's really helpful because then, David, that lends to my question, and I'm sorry I missed our last meeting, about when you say we want to follow PEB and CEB cost sharing, which of the product lines in PEB/CEB that Dave just mentioned are being envisioned, or is that your question back to us?
Yeah, essentially, well, we did choose one. Milliman modeled one, and I can't remember. I think it was the UMP Classic.
My guess would be that it would be UMP Classic that was modeled.
Yeah. So, Joan, the
Okay.
question back to you is, well, does that mean that you're proposing that to follow that UMP Classic cost sharing design per se, or would you want to consider a different cost sharing design as long as it hit roughly the same actuarial value?
Dave, I feel like you're probably more uniquely positioned to answer this too.
Well, I
Like,
figure I should
but
give a little
if-
bit more context as you're.
Because that would mean mostly co-insurance then, right? That takes us back to
It would be mostly co-insurance, and
Mostly
UMP
co-insurance,
Classic model
co-payments,
is
and pharma.
15% co-insurance is the predominant co-insurance in that product. So it's in that 85, 86, 87% actuarial value range because it's a 15% co-insurance for most things.
got it.
And most people pick the self-insured plan because
Most people pick the self-insured plan because it has the broadest network. It's the true free range PPO that has Blue Card national and international coverage. No referrals for going to specialists. It's just kind of the bread and butter product that most people have gone to. And we do have a suite of UMP products, but most people pick the classic plan, which is it's not the highest actuarial value plan in the portfolio, but it's almost the highest value. And after the closure of the plan per the operating budget, it will be the remaining highest actuarial value plan. So it's kind of like it's the most consistent plan that's been around since the late 80s, early 90s. Did I answer your question?
Yeah, that's interesting.
I think so. For me, it's just if there's a way to achieve the same actuarial value with more, I mean, what we've seen in our standard plan designs in the exchange that are exceedingly popular is when you're able to standardize them with co-payments that allow you to then easily, I guess with the universal design, you're not really comparing across options, you're just getting one. So maybe in that sense, it's less important, but at least to our customers, having standardized cost sharing as opposed to co-insurance and putting certain things before the deductible and being very intentional about the actuarial value design has been something that has been important for us, both from a sort of cost perspective and from a quality of coverage being provided perspective. Dave, I'm just trying to get my head around in the design of UMP Classic, is there room within the actual value given the network for further cost sharing and or pre-deductible services or is the AV squeezed so much that wouldn't be viable, but we could let the FTAC figure that out in Milliman, I guess.
I think I'd be more comfortable if FTAC using Milliman answered that a little bit better. Maybe is my answer. I think I'd be turning to Milliman myself to ask a couple of questions on that point. So let's have FTAC
And David,
talk to Milliman about that.
Sorry, David, back to you. You all just mirrored the classic design. So your question to us is, would there be value in looking at the sort of UMP Classic benefits with differently structured cost sharing or with more cost sharing as opposed to co-insurance to help promote access and transparency of costs for people? I would be very supportive of that.
Yes, that makes sense, Joan. And I appreciate what you're obviously thinking through, and that's exactly the kind of conversation we're hoping to have at this work group.
Oh, good. We're not even supposed to be having that conversation now. Got it. I
Well-
reserve all my comments for future work.
Joan, I
members.
think David volunteered you to be one of the commission delegates.
This has gone in a
Conversation.
terrible
I think
direction.
that's what's happening here.
I think Joan just volunteered herself.
I'm finding mute again. I'd like to make a motion to put myself on mute for the rest of the meeting.
No, I welcome that, Joan. I'm happy to talk about this subject anytime, anywhere. But I think you're right. There will be a trade-off. If you generally move from a co-insurance to a fixed copay, you're, depending upon how many people are using that service and how expensive that service is, you're at risk of increasing the actuarial value to the carrier or to whoever's funding the system. Okay. Thank you for that questioning, Joan. Okay, on the question of eligibility, you all made a decision that you gave to me to include, for FTAC to include the ERISA fully insured population. There was another question about supplemental coverage that might be available to veterans and other populations who have who enjoy benefits in one system today, but could be participants in a new unified system in the future, and how do you blend those two systems? So when I took the ERISA fully insured decision back to FTAC, there was some discussion about to what extent does the state actually have the authority to include ERISA fully insured individuals in the system. We had some discussion on that early on, nearly 2 years ago at FTAC. There was an expert who came in and talked with us about that, but I think we're going to have to revisit that question just to confirm that, in fact, what you asked us to do is feasible and possible to do. So that's where you can see in purple down here to seek that clarification. And one of my fellow FTAC members asked about the question of how non-residents were included in the Milliman study, and we didn't have time to figure out exactly how Milliman had done that and if that group of individuals was already factored into what we had broadly called the uninsured, or if that's a separate population that would have to be modeled separately. I suspect that we're talking about a relatively small number of folks, so from a cost standpoint, it wouldn't be a big driver. And as you know, there's a lot happening at the federal level right now on that subject that might guide what's possible and not possible. Next slide, please. How am I doing on time? Am I on time or? Okay. All right. Oh, okay. All right. I'm going to slow my talking way down.
You go to sleep if you.
Yeah. Yeah. I feel like I'm already inducing sleep. So on the question of provider reimbursement, we have presented to you that when you take all of the markets that we were talking about combining, that averages out to 125% of Medicare, and Milliman had modeled 6 percentage points above and below that, as well as having modeled 160% of Medicare, which is the affordability standard used in Cascade Select. You all were satisfied with the different levels that we modeled and did not ask for any additional modeling. You did ask that since Senate Bill 5083 was on the verge of passing, that be incorporated to the extent that it had not yet been incorporated. You had asked, you decided that you'd like to see differentially higher payments for primary care. And let me remember what this last one was. Oh, one of you asked, I think, Badish, you asked a really interesting question about crowding out of appointment slots for people covered by a unified system if the overall payment level was below the ERISA covered folks outside of the unified system. So we talked about that as well. So in red, you see the open questions at this point in time, the primary care payment design and the crowd out question. So, of course, we agreed to incorporate 5083 to the extent that we do have the luxury of additional modeling with Milliman, and just clarify that that's not to make payment rates 200% across the board where we started with 125%, but it's to make sure that the spirit of the bill where hospital payments are capped at that 200%. 1392 was also on the table, and that's one element of that bill is to increase professional payments under the Medicaid system to a Medicare level, and the idea would be that we would include that in future modeling to the extent that federal changes don't preclude that from happening. We were equivocal on the issue of crowding out. So one of my colleagues pointed out that a unified system at 125% of care might actually put some negotiating pressure to bring contracted rates down in those excluded ERISA covered markets. Somebody else pointed out that in today's system, point out that Medicare is also an excluded population and is obviously below 125% of Medicare, because it's roughly at 100% of Medicare. And so there might be counteracting effects because that's a fairly sizable covered population in the state of Washington. Yes.
And this might be a Joan question, but I know that there was a lot of worries when the Affordable Care Act rolled out and people got covered under QHPs. And did that have a huge impact on access to primary care? Because I don't remember. I remember people being worried about it, but I don't remember it actually turning out to be a problem. Do you remember, Joan?
Yeah, I don't remember that being a problem. And I think the Medicare, just in terms of our segment of the market, the Medicare enrollment in Washington has sort of trended to normal. And so I don't remember any access issues necessarily. But I'd have to think back a bit.
I know it was 13 years ago, 12 years ago. Yes. Okay.
Yeah, good
I
point.
might look into that just to see, because I think people worry about losing their resources unnecessarily. That and if there's no real evidence that that's happened in the past, that might help us understand any future changes.
Yeah, I'm looking at NICO too, because I know they were looking at that at a federal level as well. So I just, I don't know that it ever bore out.
Okay. FTAC members agreed that it's important to maintain differential or have differential payments for primary care, and pointed out that there are differential payments in behavioral health. RHCs have special payment rates, FQHCs have special payment rates, and that shouldn't be neutralized in a new system. And lastly, on the point of, well, what should a primary care design be? HCA does have the multi-payer collaborative that has been spending a lot of time thinking about and working on that. And so we felt that it would be appropriate to defer to that group to be taking the lead of figuring out what a primary care payment system design would look like. And then FTAC and the commission could observe as that happens and chime in and support as appropriate.
Is the multi-payer collaborative, is that the one where there's different levels of certification for primary care providers? They can choose to do more care management things to be paid more? Is that a different? I sit in a lot of work groups and I don't always remember the names of things.
I think the answer is yes, but similarly, lots of workers, I'm like, I think that's the name of that one. So I think so. I think you're right.
And I don't know if people are familiar with that, but the idea is that all the payers will pay primary care payers the same, but at 3 different levels. So you can just provide primary care and be like a level 1 certification. And then if you want to do like more care management, I'm not sure. I know people use case management and care management and care coordination in different ways, but do more kind of patient navigation, then you're level 2 and you get paid more. And then if you do even more, then it's level 3 and your payment is higher. You have to meet certain criteria. And that's not the exact description. So don't, hold me to all those.
Yeah, and I'm thinking, because I sit on one of those subcommittees to the multi-payer collaborative, and in the discussions I've been in, all of the carriers agreed to pursue certain value-based care contracting principles. I don't remember the leveling question per se from the state certification standpoint, but we did get to a point where all of the carriers agreed to follow certain principles with exceptions, where a carrier and a provider have the ability to do something different if they decide that's in their best interest.
And is the goal, I thought, was the goal for care or providers to be able to like have a good idea about what they're going to get paid. I mean, with all the different contracts, it makes it really hard to really understand, what you're getting.
Yeah, my understanding of the overall objective is to make the administrative process easier for providers so that they have a uniform set of funding principles and quality criteria that govern, how much they can get paid and what their opportunities are. Any questions on that before I move on?
Just confirming it is called the Multi-Payer Collaborative, MPC.
Yeah. Not to be confused with MCP that was recently. Okay, Jen, can you go to the next slide, please? So for the work group that we are proposing, we thought it appropriate to share with the commission members that joined that work group the next layer of detail that underlied that 125% of Medicare, just so you can see, well, what is the prevailing rate on the exchange today? What's the prevailing rate of Medicaid, uninsured payments, et cetera. This identify options for further study is just a placeholder because as we begin talking about provider reimbursement over the next couple of meetings, as Todd said, we anticipate there will be appropriate questions to come to the work group. All right, next slide, please. On the question of cost containment, which Todd introduced earlier, one of the things that we've been thinking through is, well, how extensively should FTAC be studying and analyzing cost containment strategies? And when you go back to the statute that created the Transparency Board, I think that's where we took this language from. And, essentially the Transparency Board has been tasked with figuring out the specific cost containment strategies that the state should be pursuing. And so what we've decided is that it's not a great use of FTAC's time to duplicate and do that same exact exercise outside of the Transparency Board, but to limit our cost containment exercises to what Todd showed you early on. And that feels appropriate to us. So if you have any questions about that or want to direct us differently, this would be a good time to chime in on that. Okay, next slide, please. So just emphasizing what that might look like, similar to when you asked us, actually, I'm not sure if this originated in FTAC or at the commission, but when reference-based pricing in Senate Bill 5083 was on the table, FTAC suggested that the commission support that, and you all did that. So I think that's what this would look like. If the Transparency Board were to come out with some recommendations, we'd discuss those at FTAC and provide you with our opinion on that. And I think that ends my section of the presentation. Any questions or thoughts? Okay, well, hopefully I answered all the questions that you asked me last time.
Representative Schmidt has his
Oh, yes.
hand up.
Yes.
I just wanted to ask, how does one access the materials that the FTAC committee is contemplating and using for the basis of their decisions? Is there a way for commission members to access those?
So that's a great question. All of our meetings are recorded, and so those are posted on the FTAC website. And I think the first slide of my presentation has links to those, so you can see what questions were asked, the deliberation. We, I think in the April materials, we included as an appendix the Milliman report.
Mhm.
So, that was the basis for, well, that was a culmination of 6 months worth of work and discussion, and then the basis for what I reported out to you in April. So I think for the most part, any prepared materials are made publicly available. Is that what you're referring to? Are you talking about other materials that might factor in somehow?
Just the work product that's being presented at FTAC. and from whom. I think that would be interesting. I see Vicky has posted the FTech committee, but are the materials that are considered in that committee, are you able to access them through that link that Vicky had supplied?
Yes, yeah, we have meeting packets that the Healthcare Authority staff prepares, and those packets are similar to your packet here, where there are presentations that are stitched together, and those are all posted on the website and serve as the basis for the conversations that we have.
Thank you.
Okay. And I was gonna say, in addition to that, we do our best to send, after FTAC meetings, send things to commission members, here are the timestamps, when we realize people don't always have time to sit down and watch those meetings. What we are also developing going forward is, as recommendations come out of FTAC, to say, here are our recommendations for benefits and services, or this, coming up with a formalized way to document that. Nothing fancy, but a standard format to document that, to take it to the commission. And I think perhaps that's what you're asking about, a way to track things and, have it be in an expected format when it comes to the commission.
Okay, well, thank you very much for your engagement and your questions. If I didn't answer anything, you can reach out to Mary if you don't have my contact information, and make sure we answer your questions.
Thank you, David. That was a lot of great information. I really appreciate the work that the FTech is doing and you coming here and breaking it down for us. Because sometimes when I watch the FTech meetings, I'm like, oh, yeah. So I appreciate the plain language for us. So if you could please turn to tab 7 in your meeting materials, we'll have Liz Argent from HMA and Mary from HCA do a presentation on governance and timing in the work plan. Mary, Liz?
Yeah, thank you, Vicky. I'm going to start us off. A little bit of background, which we've touched upon today in some of our public comments, some of our commissioner comments. Over the past several months, community members, some of the advocacy groups have asked the Universal Healthcare Commission and FTAC to consider addressing governance earlier in our work plan. It is one of, it's the bottom of the left-hand column right now from the work plan graphic that we've shown. And then when we brought this up, it was our April meeting, commission members asked for information about some other governance structures. So that's part of this deck that I will be presenting. People asked about Oregon, and people asked about the health benefit exchange here in Washington. And as David mentioned a few moments ago, we took this to the FTAC meeting in May and said, will moving this affect the timing of your work? Will this make your work go any faster? And they felt that it really would not necessarily benefit or make their work go any faster to move governance to a different part of the work plan. The next slide. So one of the questions was about Oregon. We had hoped our Oregon friends could join us today. They had a conflict and were unable to join us, but we reached out to them. We talked about it. They sent us a lot of their background information, and that's where a lot of this slide comes from. These are links. If the links don't work in your packet, let us know. We can send you the links to the documentation. In 2023, there was a Senate bill in Oregon that created the Universal Healthcare Governance Board. And that is a board that is working through many of the same questions and many of the same issues that our Universal Healthcare Commission is currently working through. In that bill, when it talked about the governance board, it said they shall create a comprehensive plan to finance and administer a universal health plan responsible to the needs and expectations of the residents. So similar to the charge of this commission. The next slide. I'm going to get there. I have to get their name right. Universal Healthcare Governance Board in Oregon created a number of committees. And so they have a bunch of committees working on various aspects of the work. They have an operations committee. And that operations committee in March put together a proposal for governance. The proposal came from the operations committee, approved by the governance board, and it aligns with some of the final recommendations that came out of their joint task force in September of 2022. I added the boldface here to make it a little easier to find. Public corporation for the administrative structure. And public corporations are public bodies that operate with a specific mission and with transparency to the public. So that's where the work stands right now with the Oregon folks. The next slide. Just wanted to compare that to the RCW that created the Universal Healthcare Commission. That RCW, it lists key elements of a universal healthcare system, and it lists them. And among the list is governance and administration structure, including integration of federal funding sources. But it's really silent on what sort of governing body it should be, the timing. It's part of a very long list. The next slide. Looking at the Health Benefit Exchange, again, created in 2011 as a public-private partnership, separate and distinct from the state. So that structure was in the bill that was passed, and it's also in the RCW, including design, implementation, and administrative functions necessary to operate the Health Benefit Exchange. So it's talking about a bipartisan board that oversees the functions of the Health Benefit Exchange, again, in the RCW. So I invite Joan if you want to jump in and say something if I'm misrepresenting Health Benefit Exchange. But I think in the case of Oregon, in the case of Health Benefit Exchange, the structure was, the governance structure was, I don't want to say mandated, but at least put forth and approved in the documents and in the legislation and the bills that established these entities. So I hope that background is helpful. Those were the examples that came up last time. I think now the next slide is Liz to lead us in a discussion about this.
Well, and I just want to pause because those examples that Mary shared were really in response to requests from all of you to hear some differences, and just want to see if there's any reactions or thoughts about that. And we also heard some comments in the public comment earlier about this as well, and Joan. So I want to pause before we move to the official discussion questions to see if there's any reactions or thoughts.
Breaking my own muting rule. I think happy to answer any questions folks might have about our governance structure. We were put in statute in 2011 and 2012, and then launched in 2013 for our first coverage year, which was 2014. So the legislature put the governance structure in place, and then the governance structure stood up the exchange as employee number 30. I think I can speak to the beginning. We sort of stood ourselves up and then went about the business of implementing things. So that's one model. I think the language in our enabling statute informed language that then went into the trust bill and other subsequent bills to sort of stand up. That one actually gets rid of it still. So Andra and I will have a more conversation about that at some point. But that stands up a sort of independent entity with a board sort of nominated by each chamber. And we really value our bipartisan board and our bipartisan status. We really value our public-private status, and we think it'll give us some flexibility in managing federal changes that are coming down the pike. And it's proven to give us some flexibility as we've needed to implement changes as we've moved through. So obviously encouraged as a governance structure, pretty biased, but have seen other people appreciate the flattery of other people stealing our statutory language. Hope we get to a place where the exchange is not destroyed in the context of instead leverage to implement universal healthcare, but it's a conversation for another day. Maybe the work group that I've been voluntold I will be on.
Any questions for Joan or comments from Vicky or others who were part of the effort to actually create the commission following the work group about how it was set up, and thoughts?
Well, this is Vicky, and I know am I unmuted? Okay.
No, you're fine.
Yeah, from the work group, I I don't think governance was a big topic that we had. I'm just wanted to follow up on something Joan said about the public-private partnership, the exchange versus what looks like more of a public the governing board in Oregon, and how that protects the work from any changes at the federal level. I mean, do we want to look at, I think that's important that, that the separation from the state government. I've, been visiting Joan at the exchange for many years. I remember all our different styles,
Many
haircuts, and
many lows have
colors.
passed through our doors, Vicky.
Many lows, yeah. And I've appreciated that difference in the structure of it being public, private. The tribes have a government to government relationship with the state agencies. And so that wasn't as an obvious thing with the exchange, but they did go ahead and create that kind of relationship with the tribes. But I'm just wondering about that difference between a public-private partnership or a public board, and I mostly have worked in state and tribal government for the last 30 years. So just thinking out loud if there's some kind of protection more that way.
Vicky, I would say in our experience that protection is cut both ways. So sometimes not being under the state agency umbrella helps us, and sometimes it hurts us. So I'd say just from my legislative part of my career that it's sort of a line that we've had to weave. I'll also call out that a key distinguishing factor, or potentially distinguishing factor here that should be noted, is that, the Affordable Care Act passed in 2010. It had the blueprint of what needed to get done. And then the legislature, you could use the federal exchange or stand up a state-based exchange. So the legislature stood up a state-based exchange and then said, go do it. And the thing that we were doing was very highly prescribed and regulated at the federal level. So our flexibility is really constrained by the Affordable Care Act and all these implementing rules and regulations and protections that we have to follow. Here, in this situation, the state is, I see what we're doing here as figuring out what is. Like, we are the Affordable Care Act for the state of Washington as it relates to setting up a universal healthcare system. So it truly was the what came first in terms of the Affordable Care Act, and then the governments came second in terms of the legislature deciding, okay, are we going to go federal or state? Let's go state. And then we set ourselves up and we had a blueprint already for what we were doing. We just had to enact it. So the analogous situation here would be, we're designing what is now, and then the legislature designating a governance structure and saying go do it would be very similar.
Thank you.
That's really helpful, I think, for me to hear. And I think just something to mention, I think one of you touched on this about the advantage right now to being outside of anything that's under the state because of what's happening federally. I know I've been hearing things from colleagues in California about trying to set something up completely outside of state government because of those concerns. So it's just there's just a lot up in the air right now. But I think why don't we go to the discussion slide, Mary, to really just kind of drill down onto this, because again, we're coming back to the commission now with the thoughts from the FTAC that as David shared, from their perspective, it doesn't seem to make a lot of difference in terms of their decision making. And in fact, as they said earlier, that Todd and David said that they're taking this in a form follows function pattern, and this decision about infrastructure is something also related to cost containment. So just wanted to kind of reiterate that, and then bring it back to all of you to talk about this is that one of the questions that has been, and one of the comments that we've heard from members, or from, I'm sorry, excuse me, from the public is about a decision about Model A, Model B. And is that governance discussion related to that? And is, from your perspective as a commission, do you think that that is an infrastructure issue or a governance issue? So we just wanted to open it up for that.
And just a comment again from, I don't know if anybody else was on the work group, but the discussion, I think, towards the end of the work group was really that Model A is like the goal, but we might have to get there through Model B, which is a partial insurance, universal health care, because it would be really difficult to just suddenly switch to universal health care. So I think that's really what came out of the work group. And in developing the language for the legislation, I think that was really the thought, and why incremental solutions is part of the legislation.
And so, Vicki, from your perspective, when there's public comments about governance and Model A, Model B, would making a decision about that, stop from having that type of incremental approach?
I feel like I think different from working in a, Indian healthcare delivery system is a universal healthcare system, right? It's just grossly underfunded. And so to me, the governance isn't as important as, deciding what the universal health system will look like. I think you need that first before you can get to governance. But again, I have a completely different perspective, I think, than most people.
Well, and I think
I'm sorry, when Joan was talking, they had like the blueprint,
yeah,
and then that made the exchange easy. But
that's what I'm hearing. Representative Schmick.
I got a couple thoughts about this. With the major change in the type of system that we're discussing here with universal coverage, do you want to have a totally unaccountable board making healthcare decisions? Part of what the exchange does is that even though they are a public-private partnership, there is some accountability by the members because they have to be selected or nominated. That's a better term, not selected, nominated by the legislature. How do you think the public will perceive the idea that an unaccountable appointed board in charge of healthcare, how do you believe that will be perceived by the public? I mean, with no accountability. I mean, I've read the proposals that were sent out. And I think that's a fundamental question that should be addressed or thought about and considered, because that's what you're doing. At least that's the way I see it here. Unaccountable. What happens if the public doesn't like something, doesn't like what the board's doing? So just some random thoughts, but I think they're important ones.
Okay. So what I hear you saying are the pros of doing governance sooner is that there's more accountability.
No, I am talking timing of the governance. I guess I've not really seen a compelling reason to speed it up. I am talking more about the underlying philosophies of you're asking the people to accept this, and what are the people going to think?
Okay. Thank you for clarifying that.
And Liz, I would just add, I mean, Rhett was there also at the beginning when we were getting stood up. There was a lot of, the legislature was very intentional in
Mhm.
structuring us in a way. They were faced with a decision about whether to nest us under a state agency or have us created as a state agency where the governance
Okay.
would sort of flow through the governor
Mhm.
versus stand us up as a public-private partnership where our
Okay.
accountability would flow through the legislature. So that
Okay.
was just a governance choice that was made before
Early
my
on.
day, where
Okay.
they set us, the accountability flowed to the legislature in terms of how we get our money and how we get our board, rather than flow from the governor's office in the
Sure.
state. And I do think that's a choice that you would face in standing up some sort of, if it's going to be a new entity
Mhm.
rather than a repurposed existing entity that would govern this sort of system, then the legislature would be faced with the same choice.
Okay. Thank you for clarifying that, both of you. So it's the timing is not an issue. It's more about the structure, that you like the structure of what the exchange has set up, and the intentionality of that.
Or what Rep. Schmick has stood up,
What
however you want to frame it. Yeah.
what Rep. Schmick and his colleagues put together. Okay. Padisha.
Yeah, I'll just say that, and I think I said this in the last meeting also. I would rather not move the governance piece early, like sooner. I definitely want to see the financing piece. I don't want that to be delayed. So all the design elements that are listed in phase one, I would prefer all of those before discussing governance, because I sincerely hope that the phase one design elements are actually independent of the governance. And so that's my only kind of comment over there. It's if the governance piece, if it seems like it's important to move it up before the phase two elements, I'm kind of indifferent, because there are a lot of things that are, I think, like the infrastructure and the governance part, they kind of go back and forth. So like your first question, whether Model A versus Model B is infrastructure question or governance topic, I think it could be both. So I don't see any reason to move up the governance topic.
Okay, so the conversations that the commission and the FTAC have been having, that's kind of you're happy with the progress that is being made in terms of like designing the core elements.
Yes.
Okay. Others? Am I gonna have to call on people?
It's fine. This is Nicole.
Oh, hi.
Hi. Yeah, I'm just like last meeting, still of the same opinion. I don't see moving it up, at least the same kind of what Badisha just said on the phase one. That would be not really the best spot to put it, and then also indifferent on moving phase three up near phase two. I mean, it's kind of all the same conversation as far as infrastructure and governance. So I'm okay with leaving things as is.
Okay. Other folks? Mohammed, Nico? I'm not sure what the rules are since Nico's standing in for Jane, but go ahead, Mohammed.
No, I just wanted to only add. I think I'm also will stand with my last comment in our last session. I want to go for whatever saves us time, whatever make us move quicker, because a lot of people are anxious about the universal health coverage. People are suffering right now. People are afraid and confused because of the things that's happening in the federal government. So as long as it's something that whatever we choose is fine by me, but I think timing anything that moves us closer to our goal faster than we would otherwise is what I would take. Does that make sense?
It does. It does. And I feel like what I've heard from others is that, the idea that if we did want to change anything, it would be putting the governance next to the infrastructure in phase two rather than having it at the very end. But it would be largely part of after these conversations about key pieces around what do the benefits look like, what is cost containment, what is cost sharing, what is provider reimbursement. So that's the one sort of caveat I'm hearing. And I appreciate what you're saying, because I do think the work of this commission is that much more important given what potentially we're looking at in terms of federal changes, and financing changes and affordability that everybody's experiencing. So I think that's a really, really important perspective to share. So thank you.
I'll just add, this is Dave, that I agree with pretty much everything that's been said so far, especially the last point about not making a decision that reorders things if it results in slowing things down. I will say, governance, people underestimate how important this is to people. I will say, as we've looked at the history in Peb and Seb, K-12 consolidation topic was a 30-year topic, and there were many components of it, and the ultimate structure of the board was a key part of that. As I sit here and help oversee two separate programs, and there was a conversation about potentially consolidating them, the structure of going from two boards to one is the key event. So governance is really important. And I think that goes back to Representative Schmick's point that when you're talking about something that is such a large factor in people's lives and a large segment of state expenses, there's people are going to be heavily interested in what that outcome is. And I do not think we should underestimate the importance of that piece.
Thank you, Dave. I think that's a really also a reminder that we have, in addition to the exchange board and our friends from Oregon, there's a lot we can look to from Peb and Seb. And it sounds like Commissioner Cooter was suggesting that in, I think it was September or August, that there's a conversation with Oregon folks, and perhaps that's part of that conversation with them as well, to think about those pieces and understand really what's different from what they're doing. But if the overall goal is transparency and accountability, then where does that sit in terms of timing? Okay. Anybody else? So just let me repeat back what I think I'm hearing so that we can, put this in the notes and share it again with FTAC. At this point, there's no strong feeling about needing to move up the governance conversation in the work plan. If there was any effort to move it, it would be to sort of put it in phase two alongside infrastructure. I just want to make sure that that is an accurate reflection. And we don't want to do anything to slow things down because of the urgency of big changes that are going to be coming to coverage in the state. Anything else? Okay, Mary, I'm going to turn it back to you.
Okay, thank you. I think actually that is the wrapping up the discussion, and it's back to Vicky.
Well, then I'm just gonna say, are we taking a 5-minute break again?
Sure.
Yeah. Okay, let's do them. Let me do my math a little bit better. 5 minutes from 4:07 is 4:12.
Yep.
Thank you.
All right, we'll take our break. Thanks.
All right, welcome back, everyone. If you go to tab 8 in your commission meeting materials, we'll have Liz lead us through a discussion on the next steps for the commission's work. Liz?
Thanks, Vicki. Hi again, everybody. So we have two things that are really open. We just want to have open discussions with all of you. As David shared earlier, the next topic that the FTAC is going to be focused on is provider reimbursement. And he shared some of the thoughts from the FTAC for all of you. So we wanted to spend a little bit of time hearing from the commission about what else you want to hear from the FTAC in terms of provider reimbursement. And then after this conversation, we'll then focus on transitional solutions in keeping with the Commission's direction late last year about this year's work plan. We're going to spend a second half of the year focused on transitional solutions. And so we just wanted to allocate some time with the Commission to hear about different ideas or policies or things that you want to think about for transitional solutions. But before we go to that, again, I want to go back to provider reimbursement. At the last commission meeting, you all talked about or weighed in on the PEPSA bill, as David shared. And there's a lot of other components around provider reimbursement. I think the issue that you had brought up earlier, Badisha, is another factor. But want to just hear from all of you what's important to you all that the FTAC weigh in on in terms of provider reimbursement. And David, feel free to pipe up or chime in here if you want to add anything.
And so I don't know if this is more provider reimbursement. I think it is than the next topic. But we had a really good presentation on the hospital global budgets, and I'm just again thinking about what might happen at the federal level if there are really big Medicaid cuts that will really impact our rural hospitals. And so this, I don't know, again, if this is incremental or provider reimbursement or both, but really want to think more about that. You know, I think we got the presentation, we got two different presentations, but the one where they had global budgets where it had like a baseline amount and then, you know, the reimbursement that was based on services provided. They just basically took the previous quarter's funding and used that as a starting point. And just wondering, how feasible is that to help support our rural hospitals as opposed to reference-based pricing? I mean, when I talk to our hospital administrator and the Olympic Medical Center, you know, they're looking at connecting to, I think, one of the big systems. And I think a lot of people in our community are worried about that. But what are the other choices? I mean, so does reference-based pricing, is that a better model for hospitals or global budgets? Does that make a difference if you're urban versus rural? I mean, what would we want to be in a universal system that would help keep our rural hospitals running?
I think that's a really, really great suggestion, and really ties together with the conversation, the panel that we had about rural health earlier this year and sort of the precarious situation that rural providers are in. And then I know for some folks who the cost board had an opportunity to hear about global budgets, in particular last week. I think it was last week from Bob Murray, who's on the FTAC. And he mentioned several times how this could actually be a benefit to rural hospitals because there's more assurances in terms of what they're going to get and how they're going to be supported. So, and I think, as you said, Vicki, I think this is one that falls both similar to the reference-based pricing. It's both something for now in the future system, but also something that could potentially be advanced sooner through a transitional solution. Other folks?
Liz, did you see that Bob
I'm up
is
here,
on the call and
please.
raised his hand?
Oh, no, I didn't. Thank you, David. Bob.
We have to move him over. One moment.
So Bob, oops, I muted the wrong thing. I knew I was going to do that. Bob Murray's the one who did the presentation to FTAC, and I think we watched it as part of one of our packets on the
Okay.
on the
Great. Oh, and there he is. I see him. Okay.
Yes, hi.
Bob.
I won't take long, and thanks for listening to me in the presentations. I just want to comment. I was before the cost board. I had suggested it's just more feasible to start with status quo revenue that the hospitals have been generating in a previous year, and then trend it forward to the first year of the model. But if you set up a system like this that's regulated and there's an oversight by an agency, that agency would have the flexibility to address providers that have shortfalls, or they believe that maybe their payments are inadequate or too low. So they would, particularly for rural hospitals or small hospitals that are struggling, would have the ability to raise their budgets if they felt that from a policy standpoint that it was the right thing to do under global budgets. So you have more flexibility under that type of system. But in general, it would look to use the historical payments that hospitals had been getting and surviving under. Some are doing better than others, but keep those as the basis of the starting point for the model, but then have the ability to go in and target providers that aren't doing as well and are struggling, and address those situations by increasing their payments and also funding uncompensated care. But that's a global budget model would be able to do that as well. Fund all or reasonable levels of uncompensated across all providers. So because of that, and also the fact that this flexible global budget model supports hospitals' fixed costs, it pays for their fixed costs, which is big proportions of rural providers' cost structure. Those two factors in particular really do create a situation where the hospitals that are struggling have more support under this type of approach. But that's been my experience. I see there's a question.
Representative Schmidt.
Yes, thank you. I watched the video that you did for the other committee. Are you making the assumption that most doctors now are under the umbrella of hospitals, and that there are less private practices, less individual practices, and that they are mostly all under the hospital? And then the second part of that would be, how do you address the independent providers that are still out there in the system?
When you say providers, who do you mean, hospitals or doctors? I don't know.
Doctors. Yeah,
Doctors.
there are still some private practices out
Right.
there, or is the assumption made that all of them are under a hospital system umbrella?
No, I wasn't assuming that. I think it varies from state to state and regions within a state. I think the trend is that most physicians are moving toward, being employed by hospitals nationally. In Vermont, for instance, about 70% of doctors are employed by hospitals. I don't know what the percentage is in Washington. In my thought, if you do a global budget model and the hospital's employing most of their physicians in their area, that prevents an opportunity to align the reimbursement of the physicians with the incentives the hospital faces under the global budget. So it would be a welcome development if the hospitals are employing physicians, and then the global budget could be structured to support that. And then structure it so that the physicians that are part of the hospital would have the incentives to control costs, reduce unnecessary utilization, and really kind of adhere to the same financial incentives that the hospital is now facing under their global budget. And then the other point is that under a global budget, the rate setting agency has the flexibility to add additional funds to jumpstart primary care and population-based health, with the ideas that those types of activities will save money on an ongoing basis down the road. But we need something to jumpstart this investment in population health and primary care. But under a rate-setting structure that's governed by a board, that's entirely possible. And that's the type of thing we did in Maryland, is that we provided seed funding for improved primary care and population health to get the hospitals kind of on the right track of trying to manage their costs and also reducing unnecessary use.
Representative Schmidt, do you want to respond? And then I know Nico also from OIC also has his hand up and can share some information.
No, I just had a follow-up question, because one of the things that you brought up that I picked up on is that when a procedure is not done in the hospital that is not covered by, whether it's an ASC or another type of facility, how do those enter into the system, or how are they included in the system, and how are they going to have input into what we're trying to accomplish? Thank you.
Well, it depends upon the scope of regulation. If the state wanted to pass a bill that not only regulated the hospitals, but regulated these freestanding centers, then they can be part of the overall reimbursement structure, and it can be rationalized. It just depends upon how much you want rate regulation to be applied in your state, whether it be hospitals only, or including some physician care or freestanding ambulatory surgery care. I just find it's a heavy political list to get rate setting for hospitals as it is, and to extend it to other providers may be even a heavier lift. But I think that the more the providers are under this type of structure and the incentives are aligned, and they're being paid to do the types of things that you want hospitals to do, manage care, provide uncompensated care, reduce unnecessary cost and unnecessary utilization, the better. You can do a lot. But I think regulation is best done in increments, and that's why I recommend focusing on the hospital sector initially.
So Nico, I know there's probably quite a few things you can respond to here.
Hi, everyone. And I know I'm not a commissioner, covering this meeting for Jane, but I can provide a little bit of background information from OIC's perspective on these topics. And it's a really good discussion thinking about reimbursement, in the face of some of the federal proposals that we're all looking at and thinking about. In the affordability report that OIC did from last year and presented to the legislature, what we tried to do is state-specific modeling for both reference-based pricing and the hospital global budgeting policies that would use Washington state-specific data to have Washington state-specific results. And we hope that those can be a guide to policymakers, to the commission, in looking at those policies. But before we did those analyses on those policies, we did try to delve into some of these questions about how consolidated Washington's healthcare system is and what the makeup is. And overall, we found, to Rep. Schmick's question and the discussion with Bob, is that it's become increasingly consolidated as well as vertically integrated, with the integration of some insurers with pharmacy benefit managers, other intermediaries known as healthcare benefit managers, pharmacies, and then provider groups. We also found some gaps in that, though, and just in the understanding of which entities actually employ different types of clinicians and which specialties. So that's something we noted in that report as well. But I did want to mention that final report that we did, because it does give some state-specific information. And we noted in that a policy like reference-based pricing could be done in a lot of different ways to apply just to some kinds of facilities or providers, or to apply across the board, to apply, for example, I think we, in our assumptions, assume that critical access hospitals would not be included, but that's the sort of policy discussion to have and policy decisions to make.
Thanks, Nico. And I know that, as a result of some of the, unanswered questions, there's new legislation, I think, in the state to develop a provider registry to try to get a better understanding of what ownership looks like, to kind of get more clarity on the question that you're asking, Representative Schmick. So what I'm hearing is there's a lot of interest in provider reimbursement, looking potentially at some of the information that the cost board has put together in terms of hospital global budgets, talking about that piece. And I think that's in keeping with what HCA staff is proposing to do, have a little bit more of alignment between the cost board work informing the commission. And then also looking at it from both, short term, something that could be done now, and also something that could be part of the universal system that you all are designing. And I don't want to lose track of what you had brought up earlier, Badisha, in terms of making sure that what we're doing in provider reimbursement, that there's no unintended consequences. Anything else that folks want to make sure that is brought up during provider reimbursement? I don't have the right setting to see hands come up, but I'm looking through.
Well, so talking about interest to increase coverage on services for primary care, I wonder if it's within scope to have a discussion about potentially value-based payment models for primary care
Mm.
that could really move the needle.
Other thoughts? Others have thoughts on this value-based care? It's part of the provider reimbursement conversation.
I'm sorry, did you say value-based?
Mm-hmm.
I'd be interested in hearing some more about value-based care and what those reimbursement models might look like. Because I mean, if you tie it to outcomes, that might be beneficial.
Well, and there's been a lot that's been done, so just kind of getting an overall, report out on what have we learned? Because there's been a real focus on that. Okay. Anything else before we move on to really the transitional solutions and other topics besides provider reimbursement?
Hey, Liz, this is Joan. The only thing I would add is around, it's probably a nuance of the unintended consequences discussion, but Bob, I appreciated with your presentation of the FTAC, there was a real through line in terms of how the incentives that the reimbursement structures create. So I think that was a pretty clear way of, as we're thinking about global budgeting and or thinking about capping or other cost containment strategies, just staying really centered on, like, for each of these policy choices, how the things to be mindful of as it relates to the incentives it's creating, and then from prior examples, how those have been mitigated.
Really good point.
And Bob, I was trying to remember, I think in your presentation, you also kind of had thoughts and ideas on governance that I'm not fully remembering in terms of the structure anyway, it's just interesting in light of our governance conversation that I know that was something that you had contemplated as well, but I can't remember if there's a Cliff Notes version. Would be great.
Yeah, unfortunately, with things I write, there's no Cliff Notes version, so I apologize for that. But I can certainly boil it down. In the work that I've done, just funded by Arnold Ventures, I've written a lot about governance for a regulatory agency, not a universal healthcare system. But and I've advocated a commission type of structure, like a public service commission with a board that's appointed by the governor and a professional staff. And I've thought a lot about governance. I have a lot of experience with governance system, having worked in Maryland for 15 years. So I'm happy to address that at any point if people are interested. But there's a lot of material, so I don't want to overwhelm everyone with all these thoughts that I have.
We'll keep
Well,
you
it's
on
gonna-
speed dial for phase
Yes,
2, phase
it's
3.
gonna
so-
come. Yeah, it's gonna come up in the next phases. That's for sure.
Yeah, sure.
Okay, well, why don't we go to the next question or slide, which is
I think Dave has a comment.
Oh, thank you,
Yeah.
Dave. Go ahead.
No,
Sorry, Dave.
I haven't been able to figure out how to like frame my point, and I still haven't. So that's why I kind of turned my mic off and let Joan undo her mic. So I was just, I don't know how to package this. So I'll just describe what I'm thinking. When I think about provider reimbursement today, this is why I was like, I can't think of it in a universal system right now. There's often two different ways I have to think about it. One are systems like Kaiser that have fixed overhead that has to be thought of as part of their reimbursement model and the way that they are budget based, because they're more than just an insurance carrier. They're also the provider side, and then a classic insurance carrier that doesn't have those fixed costs. And so I just wanted to say that out loud, even though I couldn't figure out how to ask for that to be counted here. It's just something that I was like, how do I reconcile that in my head? So that's just stream of conscious.
Well, it's more, yeah, it's the, having more hands-on versus hands-off and through line with the delivery system, I think. Vicky, I see your hand. Thanks for pointing it out. I can't, because you're all in the same room. There's no hand that goes
Yeah,
up. So
it's
thank
okay.
you for telling me.
No, I mean, again, going back to how Indian Health Services works, there are fixed costs. So there's like line items in the budget, and you get certain amount of money for your facilities and for the providers. And then for each tribal member that's covered, they can access care at the clinic. But then if they have to access care outside of the clinic, we have purchase and refer care dollars. And so the actual primary care provider manages the person's care outside of the clinic, and they also manage the funding for that care. And again, Indian Health Services is funded at 32% of need. For every dollar that's needed to provide the health care, the federal government only funds 32 cents or less. So if it was fully funded, I think it would work really well. But because of that lack of funding, tribes have to build Medicaid and Medicare and all that. But if that were out of the picture, I mean, the focus really is on the primary care being the medical home, and then making sure that all of the care fits with, that you're not doing conflicting care, and that they're really looking at the whole person. So it's a really good model of care. It's just grossly underfunded.
So, Vicky, from your perspective, would that be something that we should add as like another sort of focus area for the provider reimbursement conversation, like looking at how Indian Health, how you all are doing your reimbursement?
Well, I think to me that is model A,
Okay.
I mean, I think we always think of healthcare because of we've gotten into this insurance as like a fee for service, kind of system, even with managed care.
Yeah.
But I think
It's still, yeah.
That is like, to me, that is the true model A, where it's about the care and that the money kind of follows the person, which was actually a DSHS program.
Yes. Okay. Any other comments before we move to the transitional solutions and other topics? Okay, why don't we go there? So this is, again, I know there's been several ideas and things that were brought up last year that folks talked about, and just want to open up. This is a very open discussion for all of you to think about other things. I know the Medicare savings has come up before. Vicky, I know you brought up the SHOP issue. So what are these areas that folks would like to spend looking at the next, next half of the year? And I appreciate your help with identifying hands, because again, I can't see in the room. So
Yeah, and Liz, this is Mary. If I could just jump
go
in
ahead,
for
Mary.
a second.
Yeah.
if you recall, during last year, there was quite a bit of discussion about prior authorization for some time, and then the commission was taking it up. And then when we talked about the work plan, I think it was the December meeting, but it might have been November, I'm not sure. The decision was, the first half of the year focus more on the universal design, and then the second half of the calendar year pick up the transitional solutions. So we did kind of, I'm going to use an analogy, playing the record of prior authorization, we lifted the needle for a bit. I don't know if we want to put that one back down. But I just wanted to remind people, where this schedule is coming from.
Yes, thank you so much, Mary. And we did really get into the prior auth and the administrative simplification conversation towards the end of last year, so bring it back.
Joan has her hand up.
Go ahead, Joan.
Yeah, thanks, Liz. I don't know this is particularly insightful, but I know a lot of the work we're doing right now in preparation for potential federal changes that would take us in the wrong direction in terms of our uninsured rate and our coverage rate is to think about mitigation strategies there. So as we're thinking about transitional solutions, I think it's a little bit of, I think about it in the context of mitigating coverage losses as much as I think about it as
that's a great point.
Transitioning, but I think a lot of the things that the agencies are doing to think about mitigating coverage losses could potentially apply in the context of a transitional solution discussion.
Do folks agree with that? Because we were at a place where we almost had everybody covered. We had we still are in that place. We have options for everybody to be covered, and that could radically be changing in the next few months, which is there's some things we can't control about that. So just want to see if folks agree with Joan's perspective on, transitional solutions also includes mitigation or maintenance strategies, maintenance solutions to not lose ground. Okay, I see head nodding.
It's like you're trying to make decisions without knowing what the playing field is. And what will happen, probably we'll have to react, I would suspect.
Yes.
And so what I'm trying to say, it's a little difficult to anticipate what might happen. And so we can spin our wheels and say we can speculate, but we really don't know.
Okay. Thank you, Representative Schmick. I'm trying to just kind of stay up to date on that and understand what could happen, but at the same time not, count the chickens before they hatch. So others, and I'm not seeing hands, and I didn't see Joan's hand, so there must be something wrong with my computer. So Adisha, any topics that you're really interested in focusing on?
No, I mean, nothing in addition to what we already discussed comes to mind. I guess we haven't started working on that financing part yet. I know I keep going back to it because to me, it's, the other side of having this system. We are thinking about the demand. We kind of also have to think about the supply side. And with all the changes that might happen, again, we don't know what will happen. It will radically change how many people have to be covered, which will change all the estimates that has happened. So I don't know. I don't want to go back and redo, everything
all the math
government has done. Exactly. But I think that's probably where I don't know. I don't know. I don't want to add anything else. Yeah.
Okay. But folks so Vicki, you haven't said anything about the shop conversation that you brought up from, I think it was last year. Small business. Was it small business?
I feel like I have talked a lot today.
Okay.
So. But no, I do think that small business are the group of people who are hurt the most by the market. I mean, they maybe go without coverage or buy, plans with big deductibles and HSAs. And I know that at the beginning of the health plan finder, there was SHOP, which was a place where employers could purchase coverage. When I started working at our tribe, which was in 1996, mind you, Basic Health Plan had subsidized and non-subsidized plans, and we actually bought our employee insurance through Basic Health non-sub, and it was a really good deal. But then it also went away, so I think there might be some issues with that, but that the affordability of that on the state side. I'm just wondering, I think the goal to me is to get as many people under the same or similar coverage or under, coverage at the Healthcare Authority and the exchange in order to move towards a universal health system or financing or whatever we want to call it, as an incremental step. And so just trying to figure out how that would look if we could bring small businesses. I know I proposed small businesses to PEBSEB, and that's would mess up, I think, the ERISA exemption. So what are our other options then?
Okay, and based on what I heard from Rep. Schmick, it's sort of like we should continue, looking at some of the areas that we were focused on before, because they're still going to be important. And at the same time, but, and not spend all of our time on mitigation, but recognize that because we don't really know exactly what's going to happen. But to Joan's point, also making sure that we are taking a broader perspective on transitional, and transitional also means trying to maintain what we currently have in some fashion.
And just a comment on when I was talking about the IHS funding, I see the global, the hospital global payments as kind of a step towards that.
Okay. Great. Oh, Nicole.
So as you were talking, I kind of was thinking about, that piece that we were talking about, making sure that we had the providers in rural areas, and that also kind of reminded me that we should probably consider potential workforce needs in those areas as well, and what that might look like. Do we have that? Is there something that we can do in the near future to help with the workforce? And then the other thing that I was thinking about was also about something that could potentially, I don't know, be helpful and might build some goodwill with some providers, could be some sort of administrative simplification. So that way providers are using a standardized, method of billing in the first place. I think they have a form that they typically use, but it's like a unified prior authorization process, or those kinds of things, a single billing system, something that would be helpful to them, and they would only be the ones. They would be the ones that could tell us that.
Great. And I know last year during the panels we heard a little bit about that. So, okay, that's good. And I think the what you mentioned about rural workforce and workforce in general, I think that's, we definitely hear about issues with being able to access care, and I'm sure Rep. Schmick could talk about, his community a lot with that. So, okay, workforce. Okay. Anything else before we move on? Anybody in the room? I don't see any hands.
No, nobody in the room, Liz.
Okay, thanks, Mary. So I'm going to turn it back to Vicki.
All right, so that is the end of our agenda. Thanks, Liz. Thanks, Mary, for guiding us through this discussion. And thank you to all our members and those of you who have joined us and made public comments or just listening in. Bob Murray for stepping in when we had some questions. The recording and the summary of this meeting will be posted on the HCA's website for the commissions shortly. As a reminder, our August meeting has been moved to September, so September 11th from 2 to 5. And then the commission will be hosting the Advocates Roundtable July 14th from 2 to 4. And I look forward to seeing you all then. And so the meeting is adjourned. Thank you so much and enjoy your extra 11 minutes.